I'm here with Gabriel Hertz, winner of the IPA in the Community Award for Health. I wondered, Gabriel, if you could tell me a little bit about your work and for what you won the award.
So basically, I'm a nephrologist, have been for a long time, and I undertook further training to become a psychoanalyst. And there was always this quandary of when will I give up nephrology and become a psychoanalyst. And after years and evolution, in a way, I decided to do both. And I guess we're beyond the actual clinical application of caring for patients who are on dialysis, patients who are in the hospital, and also caring for patients in terms of psychotherapy. My focus is also, let's call it the area of psychonephrology, which is how to systemically, using the analytic perspective, to bring change to the hospital system. And part of it, I guess, is I have a feeling that the current medical system in today's world is focused on a very pragmatic, problem-oriented, somatic perspective, which is, what's the blood pressure, what's the hemoglobin, and there's a kind of pragmatic problem solution application of the lens that we use. And I think that sort of shortchanges the psychosocial needs of patients.
It's a human that's the patient.
The human,
in fact, a human who's in distress, having a lot of anxiety about all these changes within them and around them, right?
Oh, I agree with you completely. And certainly that's more acute in the patients that I care for, who are patients who initiate dialysis. And that in itself is a unique illness direction, in the sense that there's a daily coming to terms with the potential for death. There's the need for ongoing connection to a machine for the maintenance of survival, which introduces its own unique vulnerabilities. And so the patients present with the diverse types of vulnerabilities that are ongoing and are lifelong, as compared to other illnesses which may wax or wane, and there are periods when patients are well, or they can actually feel that they have moved on from the illness.
Yeah, so how much direct work with individuals on dialysis do you do versus how much do you work with the system and helping nurses and other physicians interact with that milieu?
Well, I guess my focus is on both, but it's limited because even in our own program, which is, again, not the largest in Toronto, we have over 600 patients on dialysis, which far outstrips the availability of any psychosocial resources for the patients. Which I guess in a way it behooves looking at systemic modifications to provide that care which is needed.
Absolutely.
And so I guess there's been a process of trying to see how can we use the analytic perspective to bring some of those changes that kind of lower the regressive manifestation, that lower the anxiety level, that provide a sense of support.
And regressive potential on the patient's part, and also maybe on the milieu's part.
Exactly. So that includes, there's the whole spectrum, which really includes the family. So usually when an individual becomes ill, it's really the whole family that becomes ill. But you're right, within that are also the clinicians who are swept up in the storm that illness finds us in. And the question then is, how do you provide support and lower the intensity at a time when one is in the middle of the storm and there's winds blowing everywhere?
I love that storm metaphor for the illness. For a long-term illness, it has so many ramifications, these kinds of kidney illnesses, where you have to be on dialysis, like you say, the machine.
Right, and I agree with you, but also I think there's an analogy that even if we escape a major illness in our lives, we do have to come to terms with aging. And with aging, there is a growing estrangement of our sense of embeddedness, so our own sense of self, feeling in a way trapped within the body that's ailing, and at times a body that becomes almost persecutory. And how do we navigate that and our different responses to that?
The ill body or the aging body being a kind of a persecutory other.
Yes, a persecutory that all of a sudden we are trapped in. And I think it's what I try to do is find metaphors with which to communicate these sensations to the medical world, which has become increasingly concretized. Moving to a further estrangement from the patient connection because of the increased use of EMR, electronic health records. And so there's a greater connection of physicians, clinicians using the lens of objective, evidence-based, pragmatic data and having very little face time with patients in that evolution.
The data is only one part of medical practice.
It's very much one part of it, and as you can imagine, several decades in the past, we didn't have that. And so there was a greater integration of what it meant to be a clinician.
Yeah.
So I guess in terms of what we've done is, one is, how can we enhance that sense of containment amongst the nurses? And so we've done that with Balance groups, where we sort of, the nurses would bring their own issues, and in that process of containing the nurses, the hope was then they would just sort of use that containment with the patients. Another method that we introduced was patients who start dialysis are most vulnerable during the first 6 weeks when they make that transition. So transitions in somatic health or illness are the areas of highest traumatization and anxiety. So providing support during those transitions, whether it's having a renal transplant or going on dialysis, I think is a very important area. So what we've done is we created transition care units where we have a greater nurse-to-patient ratio, and there's a greater focus on providing emotional support, containment, and an ongoing evaluation of where the patients are in terms of their evolution.
Yeah.
And more importantly, how to communicate that to a medical world that looks at quantitative data.
It's a different language.
It's a different language. And so what is the Rosetta Stone between our qualitative and that quantitative? And what I did was I used quality of life questionnaires,
Sure.
which allow one
Standardized measure.
a standardized measure, and lo and behold, we found that anxiety and depression were the highest when you start dialysis, and then they improve, especially if you have a higher resiliency or sense of social support. And those may make a lot of sense for us intuitively as psychoanalysts, and perhaps intuitively to the medical world as well, but they need that. There's a need for that demonstration.
Yeah. Once you see evidence, once the doctor who's based their practice here in the modern world on, unfortunately, on data and evidence base, for them to begin to see, oh, hey, there's something to this, thinking about the patient's mind, trying to heal their spirit, I suppose.
Right, and you're right. So it's evidence-based medicine. So once there is evidence, the conviction follows. And so really it's about how to enhance that need for emotional support.
Yeah.
And that's been sort of slowly removed from the lexicon of medical care. It's sort of been relegated, to social workers, to nurses, and it's been removed from the medical literature. So you don't see a lot of articles about caring or caring models within the medical literature, unfortunately. And yet we know, even from our own experiences, how important that is.
We're running low on time. Is there any other anything else that we should talk about? Thoughts that you have? I want to especially mention, like, if you have a website or anything like that.
Oh, yeah. So one of the things that we developed as well in terms of being able to communicate on a wider basis, there's a website called psychonephrology.com, and it's on Twitter, it's on LinkedIn. And there are a lot of blogs and posts and videos for patients and families and clinicians to share on a wider community basis.
Good. Okay. Gavril Hertz is one of the winners of the IPA award here in London this week. International Psychoanalytical Association, the feminine is our topic this time around. I'm Chris Heath. Thanks for following.
Thanks, Chris.
Thank you. Thank you.